Assalamu alaikum, everyone. Welcome back to another episode of the Medical Talk. Today, we have a very special guest with us, Dr. Zeenat Safdar, who is a professor of medicine at Houston Methodist and also the director of the Pulmonary Hypertension Program at Houston Methodist Hospital. And she knows all about pulmonary hypertension, is a specialist in the disease, and I'm very excited to have her with us today to talk about the disease, what's going on in the space of pulmonary hypertension, and learn more about her. Thank you so much, Dr. Safdar, for joining us.
Thank you for inviting me. Really, it's a pleasure to talk to you on this topic,
Thank
Anusha.
Thank you. Before starting to talk about pulmonary hypertension, I want to talk a bit about your journey in medicine. Where are you from? How did you get into medicine? How did you get here?
It's a long journey, as you know. It's you're starting the journey, so but your journey didn't start with applying for residency. I think the journey starts way before. I think start from school when you start to see, okay, what you want to do in life, and then you think about that medicine may be what you want to do, and then you go through the college and medical school. All this, I think, is a journey. So I think the first step for anybody is to see what do they love to do, you know. So for me, I've loved medicine, and I think that's the reason is because it is in my family. My aunt, my khala, was in medicine, and we were very close to her. So we would go to her hospital, which is Shaukat Umar Hospital in Karachi, and we would just spend our summertime. People go and play with dolls. We would go and play around the hospital campus, and spend time in the labs, talking to the patient, seeing how the labs were drawn, and how the compounding pharmacists should compound the different medications for the patient. So it just really was ingrained in me. So after completing medicine, I wanted to pursue postgrad, and at that time, America was the most place where everybody can go, and you have the equal opportunity almost to get a residency and do your postdoc training here. So that kind of propelled me. I came in after my brother, who's also infectious disease doctor here. So he came first, and after a few years, I came and started the journey of doing medicine. And then I really liked ICU medicine. Part of ICU medicine is that you combine it with pulmonary or anesthesia or cardiology or something. So I combined it with pulmonary because pulmonary lungs is affected by everything in life, right? So critical care is mostly based on cardiopulmonary physiology and the disease state that happens, and all the things that affect the lungs affects the whole body. So I did the pulmonary critical care clinical fellowship. Then I was interested in some research. So part of my fellowship was that I would spend some time in a basic science lab, doing rat research, animal research, rodent research, rat and mice. So I looked at acute lung injury in animals, and that got me interested somehow in how the physiology happens, how changes happen in the lung. And then we were in the process of setting up a pulmonary hypertension program in New York, where I trained. And then I got this really fabulous opportunity to work with a world leader at that time called Dr. Adani Frost in Houston. So I moved to Houston, and the rest is history.
That's very interesting because you see how you go from internal medicine first as a child looking at a lot of things in the hospital, then going towards residency, and then finding your particular specialty of interest, which is pulmonary hypertension. And I think it's a very interesting specialty, especially because there's so much to it. We study about it in med school, but when you actually start seeing patients, you realize that there's so much depth to it that you need specialized people to just see patients with pulmonary hypertension, do research on the disease, which is very interesting.
Very passionate about pulmonary hypertension. So, if you ask me to talk about PH, I'll talk to you about it all day long.
I actually was working with Dr. Adnani, and he said that Dr. Safdar is the guru of pulmonary hypertension. And since that day, I wanted to talk with you. And I'm so glad that we could make this happen. For the audience, for the viewers who are watching this podcast, could you explain pulmonary hypertension in very simple terms so that for even first year medical students can understand what's going on in the disease?
We talk about high blood pressure, right? So high blood pressure is you take your cuff, a blood pressure cuff, put it on your arm, check your blood pressure. That's your high blood pressure. Easy to check, right? You can say your blood pressure is high, take medicine, your blood pressure is low, what do you want to do? But in patients with pulmonary hypertension, the pressure is inside the lungs, the high pressure. So I tell my students also, there's no cuff that you can put around the lungs or the pulmonary artery to check your pressure. So it's a very difficult disease in some sense to diagnose, because from the outside the patient looks fine, but they still are short of breath, they can't breathe, they are huffy and puffy, they can't do their normal activities of daily living. And the best screening tool is an echocardiogram, ultrasound of the heart. But the problem is that not everybody thinks about it, and if you don't think about it, you're not going to do an echocardiogram because it's an expensive test. So I think the most important thing is do a physical exam and look at signs of right heart failure. So what are signs of right heart failure? Elevated jugular venous distension, loud T2 on your heart sound, systolic murmur. You will have hepatomegaly, you will have hepatojugular reflux, ascites, edema. So all signs of right heart failure. So if you see those signs of right heart failure in a relatively young person, male or female, especially in female who has connective tissue disease or just unexplained shortness of breath with signs of connective tissue disease or not, then you should consider, you can do an EKG, which is a simple thing to do, and you can see large P waves, P pulmonale in advanced cases, right axis deviation. So all those things can help you. And if you are, if the patient had a CT done, because most of these patients go to the emergency room, say, I'm short of breath, I can't breathe, it's a female. They say, oh, it must be PE. So they do a CT-PE protocol, right? And in that CT, you can actually look at the size of the pulmonary artery. You can look at the size of the right ventricle. And if those are enlarged, that's another clue that the patient has pulmonary hypertension. And of course, on the chest X-ray also, you'll see a cardiomegaly, you will see enlarged pulmonary artery. So those are the signs that you can see.
But why do you think that it's not diagnosed as early as it should be in a lot of patients? What are some of the reasons that you have noticed?
There's a lot of data out there, registry data and other data. We look at from the onset of symptoms to the diagnosis. What is the time frame? And you'll be surprised to know that the time difference is about 2 years. And we are talking about USA. We are talking about patients going to different physicians. On an average, different registries, different surveys have seen the same result. The average 2 to 3 doctors the patient has seen, maybe multiple ER visits. And then, because it's from the outside, the patient looks fine. If I bring you a patient who's, like, I don't know, I have a patient who's 26-year-old. If I bring her to you from the outside, you will not be able to tell that she has pulmonary hypertension, but she has severe PH. But you have to really talk to her. You have to really listen to her heart sounds. There's no evidence of, pulmonary edema. They are short of breath. No evidence of pulmonary edema. So lungs don't have any crackles, but they have a systolic murmur. I think sometimes it takes a very good clinician to pick up these and to really believe the patient, because sometimes when a patient comes to you with these symptoms, we usually say, oh, it's anxiety, you're stressed, I think it's too much workload that you have. The patient gets older, they think I'm deconditioned. That's why maybe I'm not going to the gym as much. So there's a lot of vague symptoms. So I can't say this is one symptom that the patient will have and you are going to make the diagnosis.
I also saw a patient recently during one of my rotations who had a completely different disease. He actually had cancer and he was in the hospital. He wasn't getting better after chemo and they had done everything. And then they found out that the patient actually had pulmonary hypertension, underlying pulmonary hypertension, which was causing all of the symptoms that he was experiencing. So, which is very interesting to see that.
Interestingly, some of the chemo cancer drugs can cause pulmonary hypertension. For
Oh.
example, dasatinib has a black box warning on it. So it's also important to see if what the treatment they got. Yeah. It's
That's
very complicated. And also chronic clots, right? Repeated PEs can cause chronic thromboembolic pulmonary hypertension.
Yeah.
Yeah.
Sometimes when I'm studying about pulmonary hypertension for my exams, it's so difficult to learn all of the classes because it's such a vast disease that there's so many causes, so many presentations.
For I'll tell you the easy way to remember it. I'll tell you. Group 1 is your main pulmonary hypertension group, right? Group 2 is the heart related, left heart disease. It can be systolic dysfunction, diastolic dysfunction, valvular problems, right? So group 2 is heart. Group 3 is lungs. You know, IPF, ILD, COPD, emphysema, all those things, group 3. Group 4 is blood clots. Okay, chronic thromboembolic pulmonary hypertension, tumor clot, any of the clots. And group 5 is miscellaneous. For example, like sickle cell, which has multitude causes, sarcoidosis, and other infiltrative diseases like Gaucher's or fibrosing mediastinitis, all the other things. So it's a simple way of remembering if you can, if you want to.
Yeah, that's actually very helpful because everyone studying for the steps has to learn about pulmonary hypertension classes, and you keep on forgetting them because there are so many and it gets a little confusing at times. But for people who want to know about the early symptoms of pulmonary hypertension, what are some of the symptoms that you as a physician have noticed in a lot of your patients? And if someone experiences these symptoms, they should come to the doctor because they might have pulmonary hypertension.
I think the shortness of breath.
Hmm.
Shortness of breath is such a vague symptom, right? You can be short of breath because of a number of reasons, right? Shortness of breath is like you can be fluid overloaded, CHF, you can have a PE, you can have, pneumonia, you can have bronchitis, you can have an asthma attack. You know, the shortness of breath is vague, but that is the one of the symptoms that is very much so. As I said, vague symptoms, shortness of breath, some palpitations, some chest pain that come and go, don't last that, it doesn't last that long. And in advanced cases, they would have hypoxemia, they would need oxygen, they will have swelling, they will have ascites, they will have evidence of right heart failure. So, think about it. If a patient comes to you, you do the exam, lungs are clear, no edema, no ascites, they're early in care. And you listen to the heart sound, which normally people don't. But if
Yeah.
you do, you are a good physician, you're going to listen. You kind of can't make out if it's loud P2 or not because you have not listened to too many of those. So you may say, oh, it's just maybe it's the S2, it's not P2, we don't know. And then there might be some grade 1 systolic murmur, and the patient on the whole looks fine. You do a chest x-ray, chest x-ray relatively fine, maybe mild cardiomegaly, that's it. And then what do you do with that patient? You say to that, oh, it's okay, you're fine, just lose some weight if you're overweight, start exercising and things like that. But the patient comes back to you again and after a few months and say, hey, I'm not getting better, I'm still short of breath. So then at this point in time, you should actually pay attention to the patient. One of my mentors used to say, if you listen to the patient, if you listen to the history of the patient, what the patient is telling you, patient is giving you the diagnosis,
Yeah.
you know and you also, it's associated with anorexigen use. So if the patient have taken some weight loss drug, not those SGLT, but the other one, like such as phentoramine, the older medication for weight loss that they used to have 10, 20, 30 years ago, if there's family history of pulmonary hypertension or cardiovascular disease. So taking a good history, taking a good family history, talking to them about other symptoms, like do they have Raynaud's, the fingers turn colors, do they have other, history of blood clots. Sometimes people say, I had a lady girl, she's 20-year-old, okay, coming to me and for pulmonary hypertension. I said, okay, yeah, well, we talked about it. Her echo looked like she has pulmonary hypertension. I asked her, did you had a blood clot? Because that's the routine, things that we asked the patient. She said, yeah, I have one blood clot about 4 years ago when I had broken my ankle, right? So it's not like untriggered. There's something that happened that caused a blood clot. I said, let's do a VQ scan just to be sure. So this girl had chronic thromboembolic pulmonary hypertension. She had multitude clots in her lungs. Multitude. You wouldn't think so, right? I would have said, no, I'm highly unlikely that she would have clot, but as a routine, we do the VQ scan. So she underwent actually, pulmonary thromboendarterectomy to take out the chronic clot from her lungs, and she had a clotting defect.
As you said, that the patient tells you the diagnosis and the history. Sometimes we wonder as medical students that why is it that since third year of med school, especially in Pakistan, third year, fourth year, final year, all we are told is take history and do the examination. But once we get to the ward, the seniors tell us take the history, do the examination, and then you realize that it's such an important skill to have because you can order as many tests as you want, but you wouldn't or even order the right tests if you don't know how to take a history, how to come up with the diagnosis, the differential diagnosis. So, which is very important, I think.
Absolutely. Yeah, and with limited resources, you can't order a bunch of tests,
Mhm.
right? So you have to tailor the test. So if you see clubbing, if you see jaundice, you know, if you
Mhm.
see loud P2, if you hear loud P2,
Mhm.
shortness of breath, then you think about liver, portopulmonary hypertension, liver causing pulmonary hypertension, liver issues causing pulmonary hypertension, which is very common, in Pakistan also. Liver issues are very common.
Yes, definitely. So, over the past years, as you have been practicing and seeing a lot of patients with pulmonary hypertension, how has the management changed? And what are some of the new things that are being done for patients with pulmonary hypertension?
Recently there's a new drug that got approved for pulmonary hypertension. Usually we have three classes of drug
Mm.
that are available: endothelin receptor antagonists,
Mhm.
PD5 inhibitors. I think those two classes are always also available in Pakistan as
Yes.
Busantan, Embrisantan, and
Yes.
the PD5 sildenafil tadalafil.
Mhm.
Now the prostacyclins are maybe not available, maybe inhaled may be available, the inhaled treprostinil, subcu treprostinil, and the intravenous prostacyclins such as ipoprostenol or treprostinil. And then we have oral prostacyclin analog that are available such as Selexipag, and then the oral treprostinil. But these are the three class of drugs, right, which have been available for 10 years. The
Mhm.
fourth class of drug that just got approved last year, March, is called sotatercept. And it's an activin signaling inhibitor. It has antifibrotic and anti-inflammatory properties, and it is given every 3 weeks as a sub-Q injection. So
Mhm.
that's the most I would say recent advance that is actually has a quite a strong life changing effect on patients, because this drug is very effective. It's not effective on every patient, but patients that respond to this drug, they have a very robust response, and some of these patients are even able to come off the intravenous prostacyclin therapy if they are on it. Yeah.
That's very interesting because, as medical students from Pakistan, when you see patients getting these new treatments and responding so well to them, it feels so good to see that where all the advancements in medicine are actually taking the patients. So it's very interesting to see all of these new therapies coming out. I was with Dr. Adani at Houston Methodist, and especially ECMO, which is such an amazing thing to have in the hospital. It's so helpful for the patients. Sometimes is very fascinating.
The ECMO history of ECMO has been around for a very long time.
Mm.
But then when the I think the viral outbreak happened in Germany, they ran out of ventilators,
Yeah.
and people had to bag their loved ones, even in an advanced country, because it was such a huge outbreak of a viral infection.
Mm.
So then they developed ECMO. ECMO used to be a very bulky, huge machine that people could not carry. And this portable ECMO actually came out of that, and they would just take these small, and you have seen those ECMO machines
Yes.
are like a little box that you can
Mm.
just hold with a handle, you can just
Yes.
hold it and take it
Yes.
and put those cannulas. To have an ECMO, you have to have a whole ECMO team
Mm.
with advanced surgery to put the cannulas in, an ECMO team who can monitor this. It is a separate than the ICU team, so it's a very advanced care. But it's, as you said, it's life changing. It can be a bridge to transplant. It can be a bridge to recovery.
We talked about the new therapies that are coming in, some of the fascinating things that are happening in pulmonary hypertension. But what, as a clinician, as someone who's practiced and seen a lot of patients with the disease, what is one of the cases that stayed with you, something that was very interesting?
Now there are many cases,
Mm.
but I'll tell you one case. I had a 17-year-old female, very young, who was diagnosed with pulmonary hypertension when she was maybe 5 year old, very young at Texas Children. So when they become adults, about 18, they transition off to adult center, which is our center. I am the director of the pulmonary lung center and the pulmonary fibrosis center at this time point in time. The girl came over to us because they asked us to take over because she was an adult at that time. She was advanced than her pediatric, so they wanted us to help manage. So we took the patient. She turned 18 and then she turned 19 and then she started asking questions about pregnancy, and she had gotten married, and I told her, you know, you're already on subcutaneous treprostinil, you have advanced disease, it will be not good for you, it will be very difficult for you to manage in terms of outcome. But she missed a couple of her appointments and she came back fully pregnant.
Oh.
So, so we had to put together a high risk OB/GYN team for her with the advanced cardiovascular anesthesia, with us, with interventional cardiology. So we had a huge team. We would meet every month, discuss the case. She was followed very closely. At the end, to the third trimester, she had some hemoptysis. She required admission. So she came into the hospital. I was actually rounding, and overnight she went into, and she was in the ICU. Overnight, the baby went into distress, and they just took her to the OR without consulting us.
Oh.
So I got a message in the morning, like 7 o'clock, that this patient has crashed in the OR, and they had to put ECMO cannulas in her to revive her. And I'm like, okay, I went to the OR. I was standing outside when she came out. Her blood pressure was 70 over 40, and her PA pressure was like 130 over 80. So you can see the pulmonary artery pressure was much higher than her blood pressure, and somebody has turned off her intravenous prostacyclin infusion. We have switched her from the sub-Q to the IV because, where the belly expands with the pregnancy, you can't have sub-Q. So we switched her over in anticipation of a C-section. So that's what happened. She crashed with induction, and she had, somebody during initiated CPR, put the ECMO cannulas and revived her. She was, they were able to revive her, but somebody switched off her treprostinil infusion.
Mm.
They switched off the pump. Not sure why. So the minute she came out, I saw her numbers. I switched the pump back on right away, and you can see that her PA pressure is coming down and the blood pressure coming back up very nicely. And she was on like 5, 6 pressors. So the requirement for pressors came down. In the end, the baby survived, of course, and she also survived. She was on ECMO for 24 days. We were able to, she had multiple complications, including pericardial effusion, pleural effusion, asystole. So she had multiple complications, but she went through all of them and she was able to survive and got discharged from the hospital.
Wow. That's
Yeah.
actually very cool because from what I know and I believe pulmonary hypertension is an absolute contraindication to pregnancy.
There's a high mortality risk, especially in the developing countries where you don't have access to all these advanced care. Because the problem is this, that in most of the other countries, you have ERA and a PD5 inhibitor. You don't have prostacyclin. If you have prostacyclin, I think there are certain countries, maybe Dubai or Malaysia, who have inhaled prostacyclin available. But when the patient gets pregnant, you can't have an ERA,
Mm.
endothelial receptor antagonist. So you have to stop a couple of drugs that they are on. You have to stop digoxin, you have to stop the ERA. Of course, you have to supplement it with other medication. But if you don't have other medications, and pregnancy puts a toll on the body. As you know, there's increase in blood volume. There's physiological changes that happen. There is anemia because of dilutional anemia. The thoracic rib cage changes, all these changes happens in pregnancy, and that takes a really bad toll on the cardiovascular system.
But this was a very interesting case. Thank you for sharing this. What are some of the misconceptions that you have seen in a lot of patients about pulmonary hypertension?
Well, nowadays, I mean, the misconception is, I think most is that it's a very bad disease, that you're going to die within 3 years, and that is based on the old data from NIH registry from 1980s.
Okay.
So I don't think that every patient follows the same trajectory.
Yeah.
Every patient has a different trajectory. Some patients are, of course, worse and they don't do well. Some patients are worse, but they respond nicely to therapy and they do well and they continue to do well till
Mm.
something happens and then they start doing unwell, and they go down the severe pulmonary hypertension road. So I think not every patient who has pulmonary hypertension should feel that that's the last thing that they're going to do, and that is they have a lifespan of 3, or maybe now the recent data suggests 7 years. With the new drugs which are available, with the new therapies that are actually in the pipeline also, I think the trajectory for pulmonary hypertension is much better.
Where do you see pulmonary hypertension in the next 5, 10 years?
I think it's going to become like any other chronic illness
Mm.
like we have. So patients will be on not just triple but quadruple therapy,
Mm.
which means basically ERA-PD5, prostacyclin, and an activin signaling molecule inhibitor, sotatercept, the new drug.
Yes.
There are other forms of activin signaling molecule inhibitor which are being tested right now in the clinical trial. So we would have maybe a better version of those also, with maybe lesser side effects. So there are a lot of drugs in the pipeline. One study looking at tacrolimus,
Mm.
which is a rejection drug
Yeah.
for lung transplant, right?
Mm.
But it also has effect on BMPR too.
Yeah.
So it has effect on BMPR. So it is also being investigated in patients with pulmonary hypertension. So there are novel drugs, novel therapies which are being tested right now. So I think there's a lot. It's a lot more to come.
Mm, definitely. And because of people like you who are working so hard in the field, it's obviously only going to get better. That's actually very exciting because even if you have someone in your family who has a particular disease and then you see a lot of research going on, there's so much hope that you get that maybe in the next 5, 10 years, it will be more treatable, it will get better, especially with all of these chronic illnesses. So that's very interesting.
Yes, I think it's a good time. I would never say it's a good time to have pulmonary hypertension, but if a patient has pulmonary hypertension, then we have more options available than we did 10, 15 years ago.
Yeah, definitely. So before we end our conversation, what is one advice that you have for people watching this podcast and mostly medical students that you think will help them in their career in the future?
I think most of the young physicians, young doctors like you, medical students, they are very hardworking. I think most students that are coming from the area, Pakistan, India, they are very very hardworking. They work hard, which is very good. They pass their exams. They do their residency. I think it's important to get involved in research if you can. It's important to never turn down any offers. If they say, okay, do this, you never say no. You go ahead and do it and complete the job as much as you possibly can. Complete it. If you have an opportunity, do not miss an opportunity, because it is the opportunity that you may not think is important, but it may turn out to be the most important opportunity that you have. So if you get an offer to write a case report or an abstract, as you did, you should avail that opportunity as much as possible. Go meet people. Always be kind. Always know your manners. Where we come from. We always should have a smile on our face. I had a resident, I remember even now, he would smile. He would smile. I mean, he would be post call, he would be dying. Like we had so much, we had such a busy schedule in my residency and internship. But he was senior too, but he would always smile. So one day I asked him, why do you always it's still nice smile on your face? He said, because then what else? I mean, that's the best thing I can do right now. I can't change the situation, but I can change my outlook on the situation. So
Mm.
always be the helping hand, always be the person that people depend on. If a nurse needs help, be kind to everybody. I don't care if it's the cleaning lady. I don't care if it is the secretary. Be kind, be nice, be smiling, because all of us have the knowledge.
Mm.
But I think as Muslims, we have to have that smile on our face, because that is the sunnah.
Yes.
And also, and be kind to others. No matter if they're mean to you, be kind, because your kindness will overcome their rudeness.
Mm.
And the truth always comes out. And even if somebody is mean to you, the truth ultimately comes out. So work hard, follow your passion. When you do your residency, you will find what you like somehow. If you like pulmonary, you like GI, you like hematology, you like whatever the field that you want to go, cardiology, you somehow gravitate towards that field, and that is what you, if that is your passion, then follow it.
This is something that's such an important thing, that smile and always help others and be respectful. And I think it's part of our culture, as all of us come from Pakistan. I think that's something that you should always have in the back of your mind, that always be kind and keep smiling.
Absolutely. And believe me, if somebody likes you, in your program in this, they will go a little bit further for you.
Hmm.
If they're even mean to you, but you're nice to them, you offer them something, glass of water, or help them out for something, they will remember it
Hmm.
always, and
Hmm.
they will go out an extra mile for you.
Yeah, definitely. But thank you so much, Dr. Safdar, for taking out the time for the podcast. I know that you have a very busy schedule, and I'm so glad that we could have this conversation. This is actually the first time I'm having a conversation about a particular disease with the doctor, and I had so much fun. And I'm going to keep this a constant thing and invite more people to talk about diseases, different diseases. So thank you so much for taking out the time for this.
Thank you very much for inviting me, and all the best to your viewers, and all the best for you for the future.